Hello, everyone. My name is Rachel Shapiro. I'm a physician assistant and the APP supervisor for the Department of Urology at UC San Diego Health in San Diego. I am also the co-editor of the Grand Rounds in Urology UroEdge Advanced Practice Provider Education Center, along with senior editor Diane Newman. And I'm so happy to be here today. Thank you for having me. And I'm excited to talk to you guys about neurogenic lower urinary tract dysfunction. This is a topic where I personally work as in a subspecialty, and one that I think is very intimidating to a lot of new APPs or even seasoned APPs who don't necessarily see this population that often. So I'm excited to walk through the guidelines with you, talk to you a little bit about my approach, and then go through some case studies at the end. The learning objectives for this talk today are to understand the risk stratification for patients with neurogenic lower urinary tract dysfunction, to review the patient surveillance at each risk stratification level, to review common treatment pathways, and to review the adjacent quality of life factors that can affect this population that we as urology APPs can help address for these patients. So I think to start, it's really important to define neurogenic lower urinary tract dysfunction, NLUTD. So what is it? And it's different necessarily than just saying neurogenic bladder, right? Because it's the abnormal function of not only the bladder, but the bladder neck and or the sphincters, and that is related to a neurologic disorder. And I underline that because it's important to have a neurologic disorder in order to qualify as having NLUTD. And even more so, it's important I wanted to say that neurogenic bladder is not equal to atonic bladder. You can have an atonic bladder for many different reasons. Atonic bladder can be because of chronic outlet obstruction from benign prostate enlargement and myogenic failure. It can be from Fowler's syndrome. There's so many different conditions that can cause an atonic bladder, but not all of them are neurogenic bladder. And not all of them need to necessarily be addressed the same way that this guideline, that our guidelines for NLUTD suggest. And especially if you are an APP who isn't necessarily as familiar with this population, and you're referring into a practice like mine or your FPMRS colleagues, it's not necessary that we always have to address these patients within the context of neurogenic bladder if it's just an atonic bladder. So that's more of a PSA, but just something to keep in mind. Okay. So who are our patients? Well, one of the really interesting things about working in this field is that our patients span the entire life cycle. So we have very young patients, those who are born with congenital disorders like spina bifida, cerebral palsy, VACTERL association. Those patients transition into adult care between usually the ages of like 14 and 21. In their 20s, 30s, 40s is when we start to see the spinal cord injury patients, the MS patients, and autoimmune neuropathies, which are becoming much more common. We see in the elderly patients, our Parkinson's, our stroke patients, our dementia patients. So we really get to take care of patients, like I said, throughout the life cycle and sometimes over the course of several of their own decades. So you really get to know these patients and have quite a continuity of care. So the goals of care for this population are, I like to organize it this way in my thought process. So we have upper tract safety. We're thinking about their renal function, their management of any metabolic stone disease, thinking about their bladder safety, bladder compliance, UTIs, how they're managing their bladder with devices, condom catheters, CIC, indwelling catheters, thinking about their continence and their bowel health, urinary continence, fecal incontinence, their bowel programs, both as a quality of life issue and an overall health issue. And then other quality of life factors such as their sexual dysfunction and fertility, cancer screening, chronic pain, and a psychosocial assessment. A lot of these patients are disproportionately affected by social determinants of health, education, proximity to care, financial constraints. Mental health, family dynamics can really affect goals of care and our ability to stay and adhere to guideline-based therapy for them. So it's important to really assess this and make sure that we're treating the whole patient. And if you look at this list of things and we think about this is really quite a lot to cover for any provider. And so it's important to have regular visits. I think this is one of the reasons why it's really rewarding as an advanced practice provider to be able to see these patients and to be able to really own this population. As an APP, I give these patients 30-minute appointment times. I know that's not always possible for everyone, but when the argument for that is that these are very high-level E&M codes, right? All of these patients are pretty much going to be level 4s. Some of them are level 5s, depending on how long they're really taking in terms of like chart review and and writing your notes afterwards. So these can be really high work RVU visits, but also very meaningful for the patients because you can go over all of these issues. I also see them very regularly. For stable patients, it can be once a year, but often it's every 6 months or every 3 months, or even more often than that if we're really, focusing on some of these issues or we're not able to cover everything in a visit. So for risk stratification, this is one of the most important things to think about when you start managing this patient population. And it's so important that our AUA guidelines put it as the very first statement. So the first statement, guideline statement 1, is at initial evaluation, clinicians should identify patients as either low risk or unknown risk, and who will require further evaluation to allow for complete risk stratification. And so what is the risk we're talking about? We're talking about risk to the upper tracts, risk to kidney function. And that's important because if we think about decades ago, the spina bifida population, young spinal cord injury patients, life expectancy was very much truncated, and that was because these patients went into renal failure. Now we understand that that had largely to do with the way that we were managing the lower urinary tract, and we were able to extend these patients' lifespan to a very normal life expectancy. But we have to keep monitoring the risk to the upper tract so that we don't allow any type of renal deterioration to occur. And it's not just a one-time risk assessment because this can change over time. I like to tell my neurogenic patients, whether it's a progressive neurologic injury or whether it's something that happened to them when they were younger that seemed like it was a one-time thing, their bladders can change over time. And so we need to keep reassessing this risk. That initial evaluation is fairly simple. It's a history to understand what the neurologic condition is and how we might expect that to progress over time. Doing a physical exam to assess their neurological function and how that will change over time, a PVR assessment, and then some people will get like a diary or a uroflow as indicated, and that's just your initial evaluation. So before we get into the risk stratification and the evaluation and ongoing evaluation, let's talk about the neural control of micturition. This is one of the things that makes neurogenic lower urinary tract dysfunction so intimidating because this neural control is really a complex process. It involves the brain, it involves the spinal cord, the autonomic and somatic nervous systems. It can be very complicated for us to understand and keep in the back of our minds when we're treating these patients. I'm going to attempt to very much oversimplify this and go through it, but I think by doing so, it'll help put into context some of this risk stratification that we're going to do. So over here on the left is going to be our diagram. This is going to show our neurologic innervation of the bladder. And I'm going to start with the storage phase. So in the storage phase, we have stretch receptors that stimulate sympathetic outflow through the hypogastric and the pudendal nerves. And that sympathetic outflow will inhibit contractions through beta-3 receptors, and then will contract a urethral smooth muscle through alpha-1 adrenergic receptors. Those sympathetic fibers are originating between T11 and L2, and that's what you see here in orange. Again, oversimplified, but that's like one of the major processes to consider in storage phase. During the voiding phase, we start to see an important role of the pontine micturition center, so up here in the pons. This is activated by afferent firing in the pelvic nerves. That's what you see in the green here. And it stimulates parasympathetic outflow to the bladder and smooth muscle through these parasympathetic fibers. These originate between S2 and S4, and you can see them here in blue. The parasympathetic fibers release acetylcholine, which produces the bladder contractions, as well as ATP, which excites bladder smooth muscle and relaxes urethral smooth muscle. Now, simultaneously during voiding, you have somatic motor nerves through this pudendal nerve, which also arises from S2 to S4, that activate to relax the striated muscle of the external urethral sphincter. Now, that is the, more complex technical neurophysiology, but how does it all work together? And so I'm going to give you guys the description that I actually give to my patients, which you're welcome to use as well, because I think it helps put things in context for patients, which is that when we're babies, we rely on this automatic process, right? Our bladders fill to a certain point, and then a nerve pathway is triggered through the spinal cord for the urethral sphincter to relax and the bladder to empty. And when we reach a certain age, usually around the age 3, we develop the brain's ability to inhibit that automatic process. And that inhibition comes through the pontine micturition center. So that's the main control switch, if you will, of the bladder. And when working properly, the brain receives this sensory information that it is getting more full. And then we decide that we are in a socially acceptable place to void. We turn off that inhibition up here in the pons, and we move into a voiding process where our urethral sphincter relaxes and then our bladder contracts to empty. Okay, so thinking about this process helps put these various neurologic conditions in perspective. For example, suprapontine lesions up here, such as strokes and Parkinson's disease, are going to be more likely to struggle with detrusor overactivity due to inability for the brain to inhibit that reflux. This next slide shows you a little bit about some spinal cord injury. So looking at this middle diagram right here, suprasacral lesions, think spinal cord injury, MS, transverse myelitis, they're going to be at higher risk of detrusor instability, overactivity, or poor compliance because we're losing some of that sympathetic outflow to help maintain bladder relaxation. So you get more of this neurogenic detrusor overactivity. And they're also at risk for detrusor sphincter dyssynergia. And the risk of these things is higher, the higher the lesion is going to be. In this diagram on the right, these lower lesions distal to the spinal cord, are more likely to have low bladder pressures. You maintain that sympathetic outflow, but then we lose a little bit of the parasympathetic outflow and the somatic function of the urethra. So these patients are more likely to have low storage pressures, but also areflexia, resulting in urinary retention or incomplete bladder emptying, and possible incontinence owing to loss of that urethral resistance. All right, so low-risk patients. So again, these are going to be your suprapontine lesions, your strokes, traumatic brain injury, Parkinson's disease, brain tumors, cerebral palsy, lesions distal to the spinal cord, patients who are spontaneously voiding with low PVRs, those who have no known complications on any prior imaging. They don't have hydro, they've never had bladder stones or recurrent UTIs, they have normal or stable renal function and upper tract imaging, and if they've gotten urodynamics for any reason, not because it's necessarily indicated for the initial evaluation, but if they had gotten it, it shows synergistic voiding, and they have stable lower urinary tract symptoms. So your unknown risk patients are going to be your suprasacral spinal cord lesions, again, your spinal cord injury, MS, transverse myelitis, spinal dysraphism like spina bifida, those who have hydronephrosis or abnormal renal function, those who have elevated PVRs, those who have a history of bladder stones or recurrent UTIs. And the reason why it's important to reassess this risk is because not everyone follows the rules. Patients who were previously low risk can then cross over into high risk. For example, patients who have like a sacral injury and low storage pressures, but also low contractility, can develop a residual over time that can ultimately lead to an obstructive uropathy. Patients who have MS who start out with lumbar lesions can then develop thoracic lesions. Patients with cerebral palsy can start out as children with synergistic voiding that becomes dyssynergistic over time. So we have to continually reevaluate this risk. Okay, so you've done your history, your physical exam, and your PVR check, and you determine that your patient is low risk. What do we do next? Well, our guidelines say that routine upper tract imaging, renal function assessment, and urodynamics are actually not indicated necessarily for these patients. Maybe reasons why you want to do this if you're bringing this patient under treatment and they're not getting better. But for the initial evaluation or routine ongoing evaluation, these are not indicated. However, they could be if the patient develops new symptoms, new complications like stones or urinary tract infections, or develops upper tract deterioration that you see incidentally on their regular labs, or if they've gotten imaging for something else. I tell my patients who are low risk that even if they're doing well, they don't necessarily have to come back to see me with a particular regularity. But I tell them if they start to develop new symptoms, or if they start to develop UTIs, or if they become bothered, that they absolutely should, because this would cause me to want to reevaluate their risk. And I tell them even if they're not bothered, they're always welcome to come back to see me, because we can repeat this evaluation on a routine annual every couple of years basis to make sure that they still maintain in that low risk category. For our unknown risk patients, you're going to start that initial evaluation for all those patients with upper tract imaging, renal function testing, and urodynamics. And it's important to consider the utility of fluoroscopy in that urodynamics evaluation. Not everyone has access to this, and urodynamics are great. So if you don't have access to it, or it's not convenient, or there's some contraindication, urodynamics is going to give you quite a bit of the great information, right? But on urodynamics, and you'll see this in a moment, what we're looking for information about, one of the things we're looking for is information about storage pressures. And patients who have who reflux up into their kidneys, some of that pressure may be transmitted up into the kidneys. And so you'll get this kind of false sense that your pressures are actually okay. When if you looked on fluoroscopy, you might see that they were holding a bunch of that urine and a bunch of that pressure up into their upper tract. So there's a benefit for doing the video. And if your institution has it, really utilizing that can make quite a difference in that risk stratification. So if you've done that initial evaluation, sometimes those patients are going to then fall into the low risk category. You will have done it. You will have realized that they actually have synergistic voiding and low pressures, and then they can be low risk for now. But most of them are going to fall back into the moderate risk or into the high risk category. So for moderate risk, what does that mean? So that's where your urodynamics is going to demonstrate some type of retention or incomplete bladder emptying with an elevated PVR. Your UDS may demonstrate that they have a bladder outlet obstruction, and that can be a neurogenic outlet obstruction like a detrusor sphincter dyssynergia, or it could be a concomitant BPH or primary bladder neck obstruction or the history of a surgical sling, but something causes this obstruction and in the context of this neurological disorder puts them into this moderate risk category. Or if they have some type of detrusor overactivity and also that incomplete emptying. If they have those things on urodynamics, but their upper tract imaging is normal and their renal function is normal or stable, that's where they get this moderate risk. And so in addition to treating any particularly bothersome symptoms to the patient, we're going to get an annual assessment for them. So they come back at least annually for a history, a physical, a symptom assessment. They get renal function serum studies once a year. Upper tract imaging, according to the guidelines, is every 1 to 2 years. It's a little bit of style points there in my practice. I do it every year since I'm seeing them anyway. And repeat urodynamics are indicated for any change in symptoms or any development of complications, including changes to that renal function or changes to that upper tract imaging. Your high-risk patients are going to be those where your urodynamics demonstrates poor compliance. So for those of you who are maybe new to this, to the NLUTD population or less familiar with urodynamics, compliance is a measurement of how well the bladder can expand to hold more volume while keeping urine at low pressures. So compliance specifically is a calculation. It's a change in volume over the change in pressure. And normal compliance should be almost infinite, right? The bladder should be able to hold as much urine and then not change its pressure at all. We consider that calculation of 20 mLs, so being able to accommodate 20 mLs of fluid increase for every 1 centimeter of pressure change to be considered like the borderline of normal. Less than 20 is to be considered abnormal. And if you're not really doing a ton of urodynamics, you don't necessarily need to remember all of these specifics, especially if somebody at your facility is actually reading those urodynamics for you. But that's what we look at. We're looking at how that pressure changes over time. We also look at another urodynamic parameter called the detrusor leak point pressure, which is when we see a leak occur when there is no stress maneuver or when there is no detrusor overactivity. And the idea here is that if a patient can tolerate a certain amount of pressure increase and then the urethra starts to leak, if they start to leak, which means they're kind of popping that pressure off by leaking the urine, if that leak point pressure is under 40 centimeters of water, or let's say it differently, if that leak point pressure is over 40 centimeters of water, that is highly correlated with upper tract changes. It's not an official cutoff point. It doesn't mean that if somebody has a leak point pressure of 39 that they're safe, but these are some of the metrics that we use to determine how much high risk someone might be for upper tract deterioration. So if your urodynamics demonstrates poor compliance or elevated storage pressures with detrusor overactivity, so what I'm talking about here is the patient who has these detrusor contractions, they come back down to a normal or to their baseline pressure. They don't have overall poor compliance, but they have this either phasic or just recurrent high pressure or sustained detrusor overactivity, which shows that they're spending a lot of time in their life, in their storage phase at these really high pressures. That would be a higher risk patient. If they have any type of detrusor sphincter dyssynergia, or if they have vesicoureteral reflux on fluoro, those are going to be your high risk patients. In addition, if any patient had, perhaps they don't have those things, but on upper tract imaging, they have hydronephrosis, renal scarring, a large stone burden, or parenchymal loss, or if their renal function testing is abnormal or unstable, these are going to be your high-risk patients. Now, in addition to treating these high-risk features in order to bring them down into a more moderate or even a low risk, we're going to want to do an annual assessment to make sure that we're not getting back into this high-risk category. So that's, again, your history, your physical, your symptom assessment, annual renal function serum studies, and annual upper tract imaging. We repeat urodynamics at the same as we talked about before for any change in symptoms or development of complications, but also importantly, after any intervention. So if I have a patient who I do a urodynamics on, they have poor compliance, and I decide I'm going to treat that with Botox, for example, I'm going to want to repeat my urodynamics after the Botox to make sure that my compliance has gone down to normal or to an acceptable range. So I've talked a lot about this upper tract surveillance and imaging and studies. So what is it exactly that we're getting? Okay, so for regular imaging, renal ultrasound is the imaging modality of choice, both for cost and decreasing radiation exposure to the patient. The patients who have stones, you may need to get the periodic CT in order to, better assess their stone burden, as well as, urogram phase imaging if they have hematuria. But primarily, we're looking at annual renal ultrasounds. Annual serum studies consider getting both creatinine as well as cystatin C. We know that creatinine is a poor proxy for renal function in the non-weight-bearing population, and cystatin C can be much more accurate, although can be less accurate in obese patients. And the difference between these can actually be quite profound. I have some non-weight-bearing patients who have creatinine that is, 0.3, 0.4, but cystatin C that is 1.5, 2.6, like this. So there can be a really big variation between these, which is why it can be helpful to get both in the non-weight-bearing population to track. A note about bladder safety. So some of these patients are actually at an increased risk of developing bladder cancer, specifically patients who have long-term indwelling catheters, history of bladder augmentation, history of bladder exstrophy or spina bifida. However, that absolute risk is not great enough that our guidelines suggest that we do any type of surveillance cystoscopy. So surveillance cysto is not recommended, but we should have a higher index of suspicion. So you have patients who fall into this category who are getting recurrent UTIs or getting recurrent hematuria, really low threshold for doing a workup with a cystoscopy, and then potentially, depending on findings or concern, urogram phase imaging. So our guidelines make a note, especially in the context of the evaluation, to talk about autonomic dysreflexia. So autonomic dysreflexia is common in spinal cord injuries above the level of T7, so T6 and above, although can occasionally occur with lower thoracic lesions. And the idea here is that a noxious stimuli, whether that be bladder distension, which is very common, rectal distension, pain, or positioning, will result in an exaggerated sympathetic outflow. And the patients will get hypertension, they get sweating and goosebumps, they get headaches, anxiety, or this sense of dread, and bradycardia. And if not arrested, this can actually be a life-threatening condition. So because a lot of the evaluations that we do, like urodynamics and cystoscopy, result in that bladder distension or rectal stimulation, it's really important to monitor these patients. I would say, at least in my practice, the vast majority of patients get symptoms before their blood pressures do go up into this dangerous level, but not everybody does. So I've had, many patients will say, oh, I'm starting to get goosebumps, and they really don't have much of an elevation in their blood pressure, and you kind of know that you're getting ready to needing to terminate the study. But I've had some patients be completely asymptomatic and get blood pressures that are way over 200, over 120. And so it's important to monitor. We have blood pressure cuffs on our patients when we're doing these procedures, and we take periodic blood pressures throughout the procedure to make sure we're not missing an acute hypertensive episode. If this were to occur, the first thing you do is terminate the study and immediately drain the bladder with the large catheter, and 85 to 90% of the time that's going to take care of it, and the blood pressures are going to go down and the symptoms are going to stop. The next intervention is to sit the patient, remove any other stimuli, including like a rectal catheter if you're doing a urodynamics, and sit the patient upright. So opposite of what we do when someone vasovagals, right? We lay them down, we put their legs above the level of their heart in order to bring blood flow back to the head. In this situation, we want to do the opposite. We want to sit them upright in order to bring that blood pressure down. Sometimes just the positioning, sitting on a hard surface or a surface that they're not used to, can actually cause a persistent autonomic dysreflexia, so you can transfer them back to their wheelchair, which can be really helpful. And if none of these interventions result in decreasing of those symptoms or decreased blood pressure, then it's important to initiate pharmacotherapy, and you should have nitropase. Nitropase is great because it's titratable, so you can use just a little bit and then go on and on as you need to if the blood pressure isn't coming down, although some places will have oral nifedipine as well to initiate if the patient is, if their blood pressure just isn't responding to any of these other interventions. Okay, so patients with indwelling catheters. A lot of the risk assessment with the low risk to high risk, a lot of that is revolving around patients who store urine, who either void or they have intermittent catheterization. But there is a lot of risk to patients who have indwelling catheters as well. And doing an assessment periodically for these patients is so important because if we are not looking, nobody is looking, right? So we got to look for urethral injury in these patients so that we can counsel them, their caregivers, their family members, their facilities about how to protect their urethras so they're not getting worsening damage, maybe convert them to suprapubic tubes. It's important to look for abnormal suprapubic tube sites. This photo here on the bottom right is actually one of my patients who is a spinal cord injury patient managed with a suprapubic catheter for a very long time. I started seeing her during COVID over telehealth, and she was telling me about this just abnormal tissue around her suprapubic tube and how she'd always been told it was just granulation tissue. And she's tried all these treatments and nothing's getting better. In fact, it's getting worse. And even I was listening to it thinking, that sounds like granulation tissue. But I had her come in and this is what we saw. And this actually ended up being an invasive squamous cell carcinoma of the bladder. And she underwent a cystectomy and neoadjuvant chemotherapy and an ileal conduit diversion. So really important, again, to take a look because if we're not looking, nobody's looking. Surveillance cystoscopy, as I mentioned, is not recommended in the guidelines, but have a high index of suspicion because these patients are at higher risk for cancers. Okay, so now moving into some of our treatment options. So we think about continence. This is a major quality of life concern for some of our patients. There's a lot of social implications for adolescents and young adult patients. It's a really important conversation to have with the patient and their family members to understand their bother and what their goals are, right? The patient who is 25 with a new spinal cord injury is going to have potentially very different quality of life and goals of care concerns around their continence than somebody who is 85 with Parkinson's or a history of a recent stroke. So just because we see incontinence doesn't mean we have to treat it. We can always offer these treatment options, but it's important to have that goals of care discussion. A note about stress incontinence. We can offer bulking agents to patients. It's important to have a shared decision-making conversation, especially in the patients who self-catheterize, as this may not be curative or may have a worsening of symptoms over time. We can offer mid-urethral or autologous fascial slings. Bladder neck closure is rare, but is something you can offer for the refractory patient. Again, shares decision-making about the fact that they're, are potentially losing access to their bladder through the urethra with such a closure. AUS is an option for patients, but all of these, it's really important to make sure that patients have safe storage pressures before offering. One of the worst things you can do is improve their outlet resistance, which is great, but then they have a really poorly compliant bladder and then they start to blow out their upper tracts. So important to get really good urodynamics before or during these procedures and make sure that you're monitoring over time so that none of these interventions are causing an upper tract deterioration. For patients who have neurogenic overactivity, we prefer, if medication is something we want to try, we prefer the beta-3 agonists over the antimuscarinics. Of course, because of the side effect profile, these patients are much higher likelihood to have constipation. We worry about the dementia risk, which could be dose dependent, and a lot of these patients would be taking these antimuscarinics over long, long periods of time. Of course, our hands are sometimes tied when it comes to insurance options, but we prefer those beta-3s where we can. We can be aggressive with onabotulinum toxin injections in patients that do catheterize. And we can consider neuromodulation in select populations, particularly the multiple sclerosis patients, Parkinson's, stroke patients who spontaneously void. Our guidelines do specifically tell us not to offer neuromodulation to spinal cord injury and spina bifida patients. For patients who have refractory overactivity or refractory poor compliance despite interventions above, we can offer surgical options. Augmentation cystoplasty plus or minus a catheterizable channel. That decision has a lot to do with body habitus, the ability to transfer to do catheterizations through the urethra, the ongoing care, complication rates of catheterizable channels, so it's a longer discussion. We can offer ileal conduit diversion, and then also an option, although I find a little less common, the pouch option, so the continent diversions with cystectomy, the Koch pouches, Indiana pouches, or Hartmann pouches. For bladder management, so for our patients who have incomplete emptying, our guidelines do make a point of stating that, intermittent catheterization is preferred over indwelling catheterization. And if someone is to have an indwelling catheter, suprapubic catheter is preferred over indwelling urethral catheter. But I do think it's important to take that patient's quality of life into consideration. This table below is just a quick tally of the time that it can take to manage an indwelling catheter over the course of a day versus the time it will take for a patient to do CIC. This can actually be increased depending on the patient's mobility too. So it is potentially 3 times longer during a day to manage CIC over an indwelling catheter, and that may not be feasible for a patient. If that isn't feasible for the patient, then trying to force them to do CIC is really just going to cause non-compliance and then further complications. So just something to think about. It's really about what the patients are willing to do and what they can commit to, and if they and what is best for their own quality of life and goals of care. So bowel health. Simple bowel management is something that I do go over with patients. Having appropriate bowel health will help reduce UTIs. It helps improve abdominal pain and distension, which can sometimes be mistaken for UTI symptoms in this population. It improves fecal continence, which can then, if they were incontinent, can actually increase risk of UTIs. So all of these things can really be improved. Urologic health is very much improved by bowel health. At any point, depending on what the patients describe as their symptoms, I might get a KUB to assess their stool burden. And I'll look at it myself. I won't always rely on the read, because sometimes I'll get, something that says that they have a normal stool burden, but then I'll look and I have these huge dilated, air-filled, stool-filled bowel loops, and those patients probably could use a clean out. So I'll often do a bowel clean out with mag citrate. The idea there being drink a bottle, you should be having clear water bowel movements. If not, take another bottle and let's try again. I will do very minimal bowel management for these patients. We'll talk about diet, we'll talk about lifestyle, those laxatives, dig stim, suppositories, example. But when those things are not working, I'll refer to GI. There are some really cool options out there for bowel management. There's some patients who get antegrade continence enemas, either through a MACE, which is a surgical stoma made out of ileum, or who get like a Mickey button or some type of Chate tube, some type of tube in order to help facilitate those antegrade continence enemas. There's also peristine irrigations that can be facilitated through Coloplast. At my institution, I found that when patients don't really respond well to the more conservative management, oral enemas, non-surgical options, we colorectal and GI pretty quickly go to a colostomy, although these other options are out there, and it's important to just know about them, because if patients sometimes come to you already having them, and it's important to get them established with the right providers to be able to continue to manage that for them. As for other quality of life issues, sex and pregnancy is really important to address in this population. This slide's a little heavy on the congenitalism population because that is one of my areas of interest, but there's a survey that was done that showed that 70% of spina bifida patients are interested in sexual activity, and erectile dysfunction presents in up to 86% of male patients with spina bifida. This is really an opportunity to discuss sexual health and protection, especially with patients with disabilities. A lot of times that falls to the bottom of the list of priorities for providers, and sometimes they can be infantilized by their parents, their family members. They don't necessarily get to have these discussions about sexual health and protection, and these patients can get STIs and they can get pregnant, and this is an opportunity to have that discussion with them. For patients who are interested in fertility, it's helpful to talk to those men who are anejaculatory about setting them up with a fertility specialist. There's electroejaculation, there's testicular sperm aspiration and testicular sperm extraction options through assisted reproductive technologies that can help them and a partner get pregnant. It's important to counsel patients, the women who have spina bifida, that they need 10 times the amount of folic acid supplementation as we would recommend a neurotypical pregnant woman in order to prevent spina bifida in their offspring. And then for patients with any type of neurologic condition, they may be concerned about the genetic risk of passing this on to their offspring. And so if you have access to a genetic counselor, referring them to that provider may give them a lot of reassurance that they actually can get pregnant and can have a healthy pregnancy and a healthy child. For cancer screening, testicular cancer screening and prostate cancer screening, this is mostly just a note to not forget about it. We don't necessarily have particular guidelines for how often we should do testicular exams on patients, right? But especially we're seeing these patients over many, many, many decades of their life. Cryptorchidism is particularly of increased risk in the spina bifida population, so doing those exams periodically is important. As far as prostate cancer screenings go, there's no published data on the incidence of prostate cancer in the congenitalism population, so we assume it's the same as the whole population. So it's important to make sure that we don't forget about screening these individuals with the same recommendations that we do for anybody else. As far as PSA is concerned, we do have to be careful because there can be a lot of labile PSAs or just chronically elevated PSAs, since these patients are either self-cathing or have chronic catheterization. So that is something to keep in consideration, but we want to make sure that we do continue to screen them. Okay, so I have a few index patients, a few patient examples to go through. Index patient number 1. So this is a 72-year-old male who has Parkinson's disease. He has a history of an elevated PSA to 4.5, and he's got lower urinary tract symptoms, particularly bothered by urinary incontinence. So we do our initial assessment. We find that he has a low PVR. We've done our history, and we find out that he's previously had a prostate biopsy in the last couple of years. It was negative. And so we determined that this is a low-risk patient, okay? So we don't need to get upper tract imaging. We don't need to get renal function testing. We do not, right out the gate, need to get urodynamics. So we can start to treat him. We start him, because he's bothered by this, or by an urgency incontinence, we can start him on the OAB pathway. If our initial efforts are not being effective, we can actually consider this patient for an additional evaluation for an outlet obstruction, for example, to do a urodynamic study to see if they actually do have outlet obstruction, and then continue on our pathway from there. Index patient number 2, this is a 27-year-old female with a T3 spinal cord injury. She's managing her bladder with CIC. She's having recurrent UTIs and incontinence between catheterizations, and she's having frequent autonomic dysreflexia symptoms. All right, so she's unknown risk right now. There's a lot of things we still need to evaluate and assess for her. So we do our initial assessment. We get our upper tract imaging, we get our serum studies, and we get our video urodynamics because we have them at our institution. And we find that with her renal ultrasound, she has left-sided hydronephrosis and she has a 1 centimeter renal pelvis stone. Her creatinine, fortunately, is 0.9. And on her video urodynamics, she has decreased bladder compliance at a rate of 10 mLs per centimeter of water, with a detrusor leak point pressure of 50 centimeters of water, and left-sided grade 5 reflux beginning at 100 milliliters of fill. So many of these things, her left-sided hydro, her large stone burden, her decreased bladder compliance, her grade 5 reflux, all of this puts her into the high-risk category. So we're going to want to start with treating her. The treatment that's offered to her is Botox 200 units. So we start with that. And then we want to recheck her video urodynamics afterward to make sure that we have improved bladder compliance and potentially improved reflux. And we want to manage her stone. And then presuming that those things are improved, then for surveillance, we want to get annual upper tract imaging and renal function testing. Now, if we were to do her Botox and then recheck her video urodynamics later, and then find that she, in fact, still has decreased compliance, at that point, we have to have this discussion with her about whether it makes sense to further escalate her Botox treatment, which can be a little bit, depending on who you talk to, some people are more comfortable doing higher doses of Botox, some people are more comfortable moving straight into surgery options with her versus continuing to monitor. So our index patient number 3, this is a 56-year-old obese female. She has cognitive dysfunction following a stroke, and she resides in a SNF, and she has an indwelling catheter. So she comes into your office, and at this initial evaluation, she is unable to communicate about her past medical history. You are provided a single dirty urinalysis and a med list that includes Flomax and daily nitrofurantoin. I mean, how often does this happen to us, right? And she's there with a 16 French urethral catheter that drains clear urine with slight sediment in the tubing. All right, so what do we need to do here? We got to start with a physical exam, right? We got to look for urethral injury in this patient. She lives in a SNF. It's unclear if anybody's paying attention to her. And this way we can go back to them and maybe advise whether she might benefit from a suprapubic catheter, or at the very least give recommendations for how to avoid further urethral injury. We need to do a med rec. We can advise against the alpha blocker, the continued alpha blocker, which could cause hypotension in this patient, and it's not doing her any good. We can advise against continuing the daily antibiotic prophylaxis, as that's not indicated in this catheterized patient. And we can have a goals of care discussion with the facility and the family if available. Now, if they're available and they wonder if the patient needs to be with a catheter, we can consider a void trial. There's a minimal role for urodynamics in this patient. Either she's voiding and emptying or she isn't, and she may need a catheter. So getting urodynamics doesn't necessarily change the management in this case, unless this is a highly motivated family that is really interested in understanding that bladder function better. There's some conversation that can be had there. It's also really important to give education, whether it's to the family, to the patient, or to the facility, about bacterial colonization, the judicious use of antibiotics, and the risks of urethral erosion. I have a nice dot phrase that I include in my AVS, or a handout that I usually send back to the SNF that talks all about this in order to help avoid the recurrent UTI patient who just has recurrent bacterial colonization but is asymptomatic. All right, and my last index patient is this 18-year-old female with spina bifida. She had a meningeal seal closure at birth. She manages her bladder with CIC, and she's been getting Botox 300 units every 3 months for incontinence. Okay, so this is a transition care patient, which is interesting, and it's actually a whole talk in and of itself, but it's an interesting population as they transition from a pediatric institution into the adult world of increasing responsibility or increasing just a lot of changes in how we manage their care. And we also know with teenagers, there's a lot of invincibility and potentially some resistance to continued medical care. So there's a lot of nuance in managing this population. That initial workup is going to consist of her upper tract imaging, serum studies, video urodynamics if she hasn't had any. I make a point of noting to do the video urodynamics after you do a Botox injection. So in my practice, I tend to wait like 4 weeks after a Botox injection to do a video urodynamics. Botox tends to take effect after about 2 weeks, so that's not a wrong answer. I just give it a little time. My goal is to understand how this patient is doing between her Botox injections, not necessarily how she is doing, when the Botox is worn off. So that would be my practice. So once I do that, I find that she has, after this Botox injection, she has persistent DO with incontinence beginning at 300, but it's not sustained, it's not high pressure DO, and she has normal storage pressures otherwise, so she has normal compliance. Okay, so what can we do for her? Well, we have our options, which is that we can just continue her current management. If she is not super bothered by the fact that she has this incontinence and that she has to get Botox every 3 months, we can continue what she's doing and just monitor with our upper tract surveillance and our, in our regular reevaluations. We can also consider bladder augmentation in a catheterizable channel if she's bothered by having to get Botox so frequently, if she's bothered by the fact that she's still incontinent, that can be an option. I do want to make a note about the Botox dose in this patient, which I alluded to before. So our guidelines actually make a point of saying that the data doesn't really show much of a difference in efficacy between 200 and 300 units. And that the data also does not show significant diminishing effects of repeated injections of the Botox. I will say in practice, that doesn't necessarily match what we see in our practice. We have found that patients will sometimes have improved urodynamic parameters and symptomatic improvement with higher doses of Botox, and will sometimes go up to even 400 units. We also sometimes do see diminishing effects over time, which doesn't necessarily mean it's due to diminishing response to the Botox. It actually could be due to progressive bladder dysfunction, but sometimes patients who do respond earlier on need to have those injections happen more frequently, or they start to not respond as well to that dosage. And then for this patient, the transition patient, it's important to look at them with a holistic approach, right? We want to consider referring them to GI. Let's make sure their bowels are managed properly. If you work at an academic institution or a large hospital system that has physical medicine and rehabilitation that has an interest in these patients, it's nice to get them plugged in, make sure that they have the appropriate mobility tools and that they, are managing any contractures, for example, that might be bothering them or affecting their ability to care for themselves better or be independent in their care. We can address sexual health and fertility with this patient, and really important to evaluate for those social determinants of health. Make sure that all of these things that we want to do are actually accessible to her. If I say, you have to come back every 3 months for Botox, but where I am working is 2 hours away from her home and she doesn't have access to reliable transportation, that's not going to happen. And then she potentially is not compliant and could ultimately fall into more of that higher risk category. So really important to have that conversation and tailor the treatment options that we're offering to what the patients actually are able to commit to. And these are my references. So I appreciate everyone for listening, and I hope that this helped demystify some of the neurogenic lower urinary tract dysfunction guidelines for you.